There we go. Welcome, everybody, to this very special November webinar that we are doing today, Emerging Trends in Peer Support with Wendy Tiegreen. And we're all happy to have you all here. My name is Al Cotton. I'm the database coordinator here at the Georgia Council, but more importantly, I'm a person in long-term recovery. What that means to me is that it has been 23 years since I felt the need to take a drink to deal with my anxiety, my depression, my loneliness, my isolation, or my legal problems. I work for recovery because every time someone seeks recovery, I want there to be a peer across the table from them. We are the best help, and that's what I know. This special webinar will delve into the latest innovations, practices, and strategies reshaping our field and creating stronger connections within our community. This isn't just a discussion, it's your chance to learn, connect, and grow with a community of like-minded peers passionate about making a difference. We will want to hear from y'all today as well. This will be interactive, and so we're going to ask for your engagement and participation. Please keep just a few housekeeping notes. Please keep your microphone on mute if you're not speaking. Everyone who attends until the end of the webinar will receive one CEU. You'll receive that certificate from me, Alvin Cotton, and it'll go out next week. Want to make sure that you search for my name, Alvin, in your inbox if you need to try to track it down. And please hang around till the end. If you are a bit late, you are welcome to stay for the content, but you may or may not receive credit. We'll just see how it goes. Please make sure your name on the screen matches the one that you want on your certificate, and include your pronouns there if you'd like us to be able to address you correctly. Today's presenter, Wendy Tiegreen, is the Director of Medicaid and Health Systems Innovation for the Georgia Department of Behavioral Health and Developmental Disabilities. She has 35 years of experience working in services directly and administration in the public behavioral health sector, with a majority of her career spent as liaison to the state Medicaid Authority. In her various departmental roles, she has led Georgia's development of the first 24/7 statewide call center, the 988 implementation, certified recovery, community behavioral health clinics, parent peer support, youth peer support, high fidelity wraparound, infant early childhood mental health, and systems of care framework for the state of Georgia.
By the time he finishes all of her credentials.
Somebody is unmuted. And just wanted to say that we're happy to have her here. And Wendy, I will turn it over to you.
Thank you so much. And I can't think of, this is actually the last day that I am doing appointments. And so for me, this is like one of the absolute best ways that I could spend my last few hours engaged with partners and in the community. Room full, virtual room full of certified peer specialists. So let me just say, it is my honor to be an ally, and it is my privilege to have led work that puts you all, as Alvin so eloquently said, across the table from so many folks who sometimes are just not feeling hopeful, or sometimes just not feeling that recovery is real. And all of you just completely debunk that by your very lives and by your very purpose. And so if you do not hear it often enough, I want you to put what I'm saying right now on rewind in your ear. You are so highly valued. You are so deserving of what I call thrivable wages, which we'll talk about today. You are just so deserving to be at the top of all the totem poles because of your wonderful lived expertise. And I'm just grateful to walk alongside you in supporting others. So thank you. You're inspirational. And I should just drop the mic with that, but there's a lot of amazing business and work ahead for you guys, and it is exploding. And so I want you to know about it, and I want you to be prepared for it, and I want you to be driven by it, because so many folks recognize the beauty of peer support, and they recognize your niche experience that is just unparalleled because it's lived experience. And so I've got a lot of news and information to share with you guys. Some of you who may be more policy wonks, maybe more attuned to some things in the ether, some of this may be old news. However, many of us are going about our daily work and delivering service and writing progress notes or facilitating meetings and recovery dialogues, and you're not tracking on this. So just stick with me through it, and hopefully you're going to learn some nuggets of good news. And some of you may have heard me do some things recently, and so some of this may be a repeat, but if so, repetition is the key to adult learning. And so we will continue to help grow you as we move through this dialogue. Okay, so one of the things that the team at Georgia Council asked me to talk about very specifically is that the federal government has a mental health and substance abuse agency, and it's called SAMHSA, the Substance Abuse and Mental Health Services Administration. And they have recently released what are called the National Model Standards for Peer Support Certification. That's long, right? Basically, SAMHSA is responding to something that was rolled out under President Biden and the White House, which is great. Like, the White House is recognizing peer support, y'all. I mean, what is wrong with that? And they had a game plan to address what they were calling at that time a national mental health crisis. So folks were coming out trying to emerge post-pandemic, and everybody was really realizing that behavioral health had become just addressing behavioral health had become critically imperative because of all the behavioral health concerns that were just out and about during the public health emergency that was COVID-19. So folks had more anxiety, folks had more depression, folks were isolated. So sometimes recovery was hard to sustain or hard to find a pathway to. We were, doing telesupport in a lot of cases, so normal systems of support weren't available. But the goals that were identified are really where some stuff has begun to emerge that is really pretty amazing for the peer workforce. So if you look at the goals that I've called out, and it was multiple pages, multiple aspects of behavioral health care, but I've pulled out the peer specific items. And one goal was to accelerate the universal adoption, recognition, and integration of the peer mental health workforce across all elements of the healthcare system. So don't get bogged down with me on the mental health part of this, right? It was a mental health strategy. But SAMHSA, because they are a mental health and substance use agency, they took this directive, right? And they made it applicable to both substance use and mental health. So just bear with and kind of set aside that mental health and substance use concerns are not the same. We know that. Like, we're in the know, but the folks who are really writing this out of the White House were just focused on mental health, but SAMHSA broadened that. And then the second kind of critical piece was they said that they wanted the implementation of a national certification program for mental health peer specialists. And after that, once this was released, like, SAMHSA started talking with executive leadership. Folks around the country started like chiming in on this. And one of the things that they really came to the conclusion about was gosh, there are so many amazing local certification entities and curricula and programs. And if there was a single national certification, like who would hold that? Who would credential that? Who would sign off on that? How would that decision be made? So they slowly started backing off the idea of a national program and instead said, let's create a set of national standards. So we don't want some nonprofit sitting, in the middle of some state saying, if you pay me $500 and you attend a 1 hour virtual training, you too can be a certified peer specialist. There was a lot of concern that more of those things might crop up. And if they didn't have a national standard against which to look and be reviewed, that then we could have more and more variation on these things. We might have folks who don't even have lived experience leading these initiatives. They might not really have a sense of what we are all talking about, and now is like in Georgia, like so normed. Like the Georgia Council's curriculum, Georgia Mental Health Consumer Network, Georgia Parent Support Network, like with integrity, like we've all worked together in partnership to build this stuff. But we've even been surprised, like a couple of universities have just popped up an online, training and said, oh, for $395, you can get certified as a peer specialist. And then I call and I holler at some people at a university and they take it down. And so there's like a lot of real question and variability. So in order to then try to meet the purpose and the mission of what the White House said, SAMHSA came back with a set of national model standards. And so here are like the reasons why for this then. And so I was dropping a few of those into kind of the dialogue as I was sharing this, but let's just really talk about what the named premises and assumptions were for the federal government saying we need a standard. So one, the system, the public behavioral health system, really needs to have strengthened system capacity. And if you think about that, this was released in 2022. What happened in 2020 also was that there was a new federal law passed that lifted up and named 988 as a 3-digit crisis call center number and outlined all of these crisis services that states needed to provide in order to stabilize an individual who may be experiencing a crisis. So there was that going on. We have a huge behavioral health workforce shortage. And that ranges from the most schooled practitioners like a psychiatrist, all the way to certified professionals, certified practitioners, paraprofessionals, community health workers. So huge shortage, a need to expand the supply of the workforce. So the White House, their basic assumption is peer specialists are awesome. Like they decided to lift them up, and they say they needed more, but you don't need more if it's not folks going through a quality curriculum and for whom then they've been tested. They've like demonstrated some competencies, been through a quality training program and the like. We need to expand diversity and cultural competency of the workforce. And, one of our, greatest concerns is like behavioral health policymakers and administrators is that folks are best supported when they feel like they can identify and create a relationship with the person across the table. Alvin, I'm going to use that the whole afternoon. And you all come together with folks based out of your shared lived experience. But it would also be awesome sometimes to see, maybe some gender matching, or that somebody had the same color of skin, or had the same religious or ethnic or cultural backgrounds. All of those things have been researched to be critical ways that folks can get and achieve some wellness and recovery at a faster pace. And then, of course, everybody, which is really nice, like, because when peer support started, people threw things at me, I felt like. But now people are really interested in this universal adoption of this peer workforce across the board. And so what happened then is the White House brief, all of these premises and assumptions. Then what ended up happening too was that Congress ended up funding SAMHSA to establish its Office of Recovery. So all these years, SAMHSA has not had an Office of Recovery. They've had, a mental health center, and they've had a substance use center, CSAT, for those of y'all who are familiar. They've had other offices, but they did not have an Office of Recovery. So they set forth an Office of Recovery and then gave that office certain charges of things to accomplish. So very exciting. In 2022, this office was established, and Paolo Del Vecchio, who's a person in long-term recovery, it leads that office. So then what has emanated as one of the first major projects out of that office is what's called the National Model Standards for Peer Support Certification. So this product really says, here is a set of standards that all certification and training entities need to meet in order to say that they are really doing peer certification. So couple of key things about that is that they brought together peer specialist leaders from all over the country, and they pulled together kind of all of their thoughts on what are the floor practices in order to be a training and certification entity. That included having tribal leaders and territory leaders, local partners, national partners, right? Like folks from like national organizations of Faces and Voices of Recovery were at the table. The National Federation of Families were at the table. The NAMIs and Mental Health Americas at the national level were there, as well as a lot of local folks and state leaders, local providers. And they made a decision that this National Model Standards document should address substance use, it should address mental health, and it should address family peer certification. So where a child is being provided peer support and needs a practitioner for improving their resilience and wellness, that parent peer specialist and youth peer specialist would also be included. And that this is not a mandate. While a national certification would have been a mandate, it was too rigorous, too onerous. It put too many awesome training and certification entities at risk if somebody was going to assume that role and function just nationwide. And none of us who are fans of Georgia Council or Georgia Mental Health Consumer Network or Georgia Parent Support Network would have been happy. We would have been quite frustrated. But in order to kind of get close to what the White House had originally set forth as a vision, the standards needed to be out there. So it's not a mandate, but it's more of a quality improvement document so that states can or entities can be aspiring to really have all of the content met. So the emphasis area and the standards are outlined here, and I'm not going to read all of this, but I just want you to see the main headers. So the main areas were authenticity. Is there really a peer specialist leading the work? Diversity, equity, and inclusion and accessibility was the next area. Ethics, then examination. So are you going through a test at the end, and can you demonstrate that you learned the content? Content on cost and fees, and content on the training and the hours of most of these certifications. So you can kind of read in that sub detail and some of the standard examples that I've kind of culled out here for that each of those unique standard emphasis areas. Oh, and it goes on, I forgot. Second slide. Supervised work experience, background checks, formal education, recovery, and peer supervision. And so that concludes the list. So the document also has an Exhibit B, which really says, does our entity, does our certification entity really kind of meet these standards? And do we have everything in place we need to have in place? So they really want to promote that entities are looking at all of this work, and then they would self-declare, self-certify, we meet all of this, we meet the model standards. At which point, maybe after a few years of this being out there in the ether and all of this quality improvement work has occurred, then maybe states can get to a more normed reciprocity. And reciprocity, for those of you who haven't had to experience it, really is saying, I have some credentials, and if I go do something else or move to something else, because I have these credentials, I could also do that work somewhere else. So, if you were a bank teller from Wells Fargo and you wanted to get a job as a bank teller at SunTrust, they would go, oh yeah, like this is the same skill set. You were trained in basically the same information. Sure, you could go from being a Wells Fargo bank teller to a SunTrust bank teller. Oh, Truist, right? Sorry. I think that's changed. And that would happen. So maybe you live in Atlanta right now, but you're thinking about moving to Dallas, Texas. So would Texas certification bodies recognize the Georgia certification bodies? Have they done the analysis before to be sure that you have similar content? Well, if there was a national standard, then you can slowly begin to say, yeah, I'm a certified peer specialist in Georgia, and therefore I will be accepted in other places. So it gives more portability, more flexibility for peer specialists, but that's kind of a long range goal, but a very important one. And so, what we've been working on lately in Georgia, this tool was created by me for another state. The federal government funded me to work with another state in developing a tool to take the model standards and really create a tool for self-assessment. And so for your information, myself and the department leadership at DBHDD, the Office of Recovery Transformation, under the awesome leadership of Dana McCrary, plus the Georgia Council for Recovery, the Georgia Mental Health Consumer Network, and Georgia Parent Support Network, we've been meeting on a regular basis, and doing the work of each of those entities self-assessing against all of these standards and identifying where we are like, yes, victory, we meet this one, or we're a little shy of meeting that one, and what do we need to do about it? And so it's been an amazing quality improvement initiative and a very important quality improvement initiative. And so we're very excited about what's to come. This just gives you a little bit of information on what the Georgia Council team has been working on to kind of self-identify. They're going through and like literally looking a standard at a time at what you see right in the middle, which is what is the current state evidence that we meet this? What are the gaps? That's the next to the last column. And what are we going to do to create some improvements ahead? So if we're not quite somewhere where we want to be when we read this standard, can we go after a grant together? Can we leverage, some funds between and among the three entities and maybe lift something up so that everybody in Georgia can put a check mark by it? And then that would be, an incredible step to be able to say, yes, we meet all of them. Just so you know, in Georgia, we are what I would call like substantially compliant with most of these, and feeling really good about that. There are some aspects in here that were real stretch goals. Like, is the certification offered in multiple languages? And are all the documents available in multiple languages? Is there a deaf certification, which Georgia Council has worked with our department on, which is really amazing. For like the parent and youth and mental health specialists, that's not in play. So we've got some real work to do on accessibility. And so it's not that anybody is feeling like any of the curricula are in any way subpar, because I think we've been the national leader and we are at the top of our game in terms of our content. But there's some things about accessibility and diversity and equity that are real opportunities for us to try to grow and expand. So a lot of that's on the horizon for the future. So again, like you've already heard me allude to these things. So the work ahead is really going to be focused on quality improvement. Like now that we've done some real rigorous self-assessment, like what can we do to feel like we've got an A+ on any of those standards? Two, our standardization across the board. There's some things that it would be really helpful if the three certifying entities in Georgia had more alignment on. So for instance, everybody's got their unique ethics, but how are people reviewed against their ethics if there's a complaint? So how might the three entities be more standard and create some joint or aligned protocols about that whole process? And then again, like, I feel like what's on the horizon, like in maybe 5 years, is SAMHSA might come back and say, we are going to make these mandatory now. You've had a few years to work on them. And if everybody can self-attest to meeting these standards, maybe we have more reciprocity than around the country. And maybe if you're a peer specialist who lives in Augusta, you could go over to a mental health center in North Augusta and actually do some practice across the state line, because you would be recognized in both states. It's for you, it's just, a 10-minute drive, from your house, over to, the other side of a river. But in that case, you can't practice in that other state. So this could be a real opportunity for, again, kind of expanding our workforce horizon. So all of the stuff that we're doing, that we're talking about so far has been really specific about the curriculum. The other awesome thing, though, of this manual that was released is that it started to really talk about supervision and talking about who can supervise, and kind of poking a lot at the federal Medicaid agency and their rules about supervision. So this document started saying that really supervisors in the most ideal scenario, in the best of practice, should be peer specialists. And many of you who like function like in a recovery community organization, or maybe in some like wellness respite centers, there's a peer that's supervising that work. But under Medicaid, there were some real restrictions that indicated that you had to kind of have a higher order license or an executive type certification in order to do supervision. So when this document came out, what was really awesome is that it kind of poked at its sister agency, right? So at the federal level, there's a federal Medicaid agency, there's this federal SAMHSA, there's sister agencies. CMS was real rigid and real restrictive on supervision, but then like all of a sudden SAMHSA's like, we're putting standards out here to say it needs to be a peer specialist supervising when we can. And because of that, what's really awesome is there's been some movement on this front that I'll talk about in a moment. So again, like the really neat thing is I do want to like share that Georgia actually had this document and this convening in Atlanta at the Carter Center in the early teens. And we actually published a report called The Pillars of Peer Support Supervision. And it really talked about the desire to have peer specialists be supervisors for folks. But we had hit a wall continuously with federal Medicaid. The pillars of peer support supervision, it said that peer specialist supervisors should be trained in quality supervisory skills, that the peer specialist supervisors understand and support the role of peer specialists, which who better to do that than somebody who has practiced as a peer specialist. That peer specialist supervisors understand and promote recovery in their supervisory roles, that peer specialist supervisors advocate for the peer specialist and peer specialist services, and that the peer specialist supervisors promote professional and personal growth of the peer specialist who they supervise. And again, you see, we published this in 2014, again, under a convening and partnership we did with the National Association of State Mental Health Program Directors and the Carter Center. So the miracle then that happened only 10 years later, sometimes we have to wait with patience, is that this summer, federal Medicaid has come back to the table, and they have added that they are changing their opinion on peer support certification. And so we're very excited with the clarity that was offered in this particular memo. And here are the major messages that they released on June 5th of this year. One, they go into a formal declaration that they endorse the training and certification entities that use the SAMHSA national model standards. So the two sister agencies are like, woo, look at us, we're getting in alignment, which is awesome. They say There has remained questions from some states about parent peer support. And does a parent's lived experience qualify as peer support? Well, we've known that in Georgia since we began building it in 2010. We've believed that. And so along with our partner, the Georgia Parent Support Network, have endorsed training and curriculum and certification for certified peer specialists that are parents who support other parents in their lived journey. So SAMHSA reinforced that. They had already reinforced that in a 2018 memo, but this was one more reinforcement of that. They also reinforced that youth peer specialists are critical to supporting young people because of that lived expertise and early lifespan experience. So it reinforced that, which was great. It reinforced that mental health peer specialists and substance use peer specialists are both quite important, and that sometimes those conditions co-occur. So standalone curricula or blended curricula were both okay. It recognized that coordination is crucial, and that all peer specialists should be trained in understanding how to coordinate and partner with other resources and other supporters as they engage in peer support services. And they reinforce that children who are on a particular type of Medicaid, so there's a Medicaid called CHIP, the Children's Health Insurance Program, and those are children who just can get on Medicaid or can get Medicaid just because they have very low income. So Medicaid, the base type of Medicaid is for folks with disabilities. But the CHIP program is just for young people who are poor. And so you don't have to have like a major disability condition to get CHIP coverage. If you're low income and provide that documentation, then you as a young person can actually get a very comprehensive health insurance package through Medicaid. And they just reinforce that peer support is covered under the CHIP program as well as the Medicaid disability program. So the awesome thing that they mentioned that I think is important for all of us to talk about too, which wasn't thematic, but was just very direct. Is a point, like not a theme. So CMS says they strongly encourage states to expand the availability and utilization of peer support, which love that declaration. That is huge by saying everybody should be growing this. I'm like, yes. And then secondly, it says, oh, and by the way, this should happen in emergency rooms and in inpatient settings. That's quite interesting because one, Georgia Council is already doing a lot of work in that space, which I love. Georgia Parent Support Network is as well. There's some emergency room stuff going on with CHOA. And so we were delighted by this. The interesting thing is that the way emergency rooms and inpatient settings are paid is like a bundle payment that pays for docs and nurses and social workers and orthopedists, all the specialists that work in a hospital. And so really then that means peer specialists can start to get credentialed in that space, but a lot of hospitals don't know how to do that. Kudos to Georgia Council for Recovery in how this was all rolled out about 10 years ago to start developing some of this work locally with some hospitals. And so y'all are kind of on the cutting edge here. And then this beautiful statement right here, which says CMS encourages states to ensure that payments actually support a living wage. And I keep converting that to living wage means you can get by. Thrivable wage means that you actually can breathe. And so I keep using the thrivable wage, but this is a very important statement because I think it helps CMS say to states, this rate may be too low in places around the country, not in Georgia, because y'all hold on. Because there's some more slides at the end about that. So the supervision direction that we got is that the state can actually expand its definition of who can provide supervision of peer support services and therefore certified peer specialists who can supervise their work for Medicaid billing. And again, that's the most restrictive side of supervision. Again, tons of other stuff is super flexible. There's peer specialists already providing supervision, but Medicaid's like the most old school, traditional medical model. So the fact that CMS is saying now that this can be done by certified peer specialist is really incredible. And they make clear in the second bullet that substance use treatment specialists, folks who are certified, licensed and unlicensed, are all allowed to be considered in supervision. And the last statement is the one that is really the thing of beauty, where they are very clear, very directive that other peers can provide the peer support supervision, which is what I've been kind of reinforcing, but there's the statement that they made. Okay, so with that, I do want to just share that, again, the leadership teams of the 3 training certifying bodies have been coming together with my office and the Office of Recovery Transformation out of DBHDD. And we have been drafting what we hope to propose for this in the future for a change to Medicaid's policy. And I just want to share with folks, changing Medicaid policy is a state-by-state thing. So federal Medicaid has said, this is okay, but it's not like Wendy Tiegreen is sitting in my office at DBHDD writing this kind of policy. When it's something that is in a Medicaid plan, states have to write down what they want to do in their state, and they have to send it to federal Medicaid. They have to review it and ask 99 questions, and then they send it back and they say, this is approved. That becomes your boundary for what you do in that moment. And until you go back to the Medicaid agency in Georgia, the Medicaid agency board in Georgia, go through a hearing process, go back to the Medicaid agency board, get their approval, send it to federal Medicaid, have federal Medicaid review it, go back and forth with them asking questions, get an approval, and then put it in policy. That process usually takes a year. So we began a couple of months ago as a leadership team of the lived experience training and certification agencies, plus DBHDD, in drafting some ideas on this. And so you've had beautiful leadership from your team, the Georgia Council team, from the Georgia Mental Health Consumer Network team, and from Georgia Parent Support Network, sitting at the table with us and kind of hashing out some of these ideas. So stand by, because I think there's some exciting work ahead. Okay, so now I'm going to shift us for our last little bit. And I'm going to talk very much about that thrivable wage. For Medicaid reimbursement in Georgia, there are a couple of ways we pay for things. So the state DBHDD actually co-pays with Medicaid for reimbursement rates. So our agency pays 32 cents for every dollar. And then the Medicaid agency comes in and they pay the remainder that they actually get from the federal government. So a Medicaid reimbursement rate has to be paid for by the state, and that's done through DBHDD right now. And then the state Medicaid agency goes to the federal government, bills them, and the other part of the dollar comes back to Georgia through federal Medicaid and then creates the reimbursement rate. Now, we don't wait for that to happen. We pay first and then we reconcile in the background. But if you've ever wondered, kind of like when people talk about the federal Medicaid budget and how that applies locally, it really means something. So the feds actually are paying for, in Georgia, it's a different rate in every state, but in Georgia, they pay about 68 cents of every service delivered. And so, sometimes when we pay our taxes and we groan a little bit, just know it's paying for peer support. We're paying for our federal taxes and our state taxes. It's paying for a lot of other things too. I know that you might want to groan about, but today I'm going to talk about the peer support part of this and where this money rests. But again, for Medicaid, you have to go through all this rigmarole in order to get rates changed. And in order to have the conversation and even start the conversation, generally the state has to have the support of the legislature and the governor's office to really embark on a significant rate study. And because those are expensive to do. And then you have to have their support because at the end of that rate study, rates need to be adjusted. And that means sometimes a new appropriation out of the Georgia legislature. So about 3 years ago, we got the green light as a department to look at our 4 main Medicaid programs. So under behavioral health, which is mental health and substance use, we have 2 programs. One is a psychiatric residential treatment facility program for children. It's a residential facility for children. And we have community behavioral health rehabilitation services. And then we have 2 programs for individuals with intellectual and developmental disabilities. They're called Medicaid waivers. I'm not sure if you've heard of those before, but it's a good reference to know. We have something called the comp waiver and the now waiver. And they support individuals through our department with major intellectual and developmental disabilities in helping them lead community-based lives. And that's a comprehensive benefit to help those folks. I'm going to focus today on the community behavioral health rehabilitation services, because while the legislature and the governor supported us in doing rate increases and studies across all 4 of these, peer support lives in the place where that gold star is, which is in that particular bucket. And when I say peer support lives there, it lives there as a list, as part of a list of services, which includes psychiatric treatment and individual therapy, group therapy, psychosocial rehab, substance abuse intensive outpatient, case management services, children's community support services, children's intensive family intervention. All of those things, it's a long list of services that live under this umbrella called community behavioral health rehabilitation services. So we got approval from the legislature to embark on this rate study. So the governor and the legislature supported it. We completed the rate study in 2023, and that's a huge process, huge body of work. All the providers are like surveyed. They have to present money and wages and insurance benefits and continuing education benefits, and the cost of their buildings, the cost of their car insurance, the cost of their paper, their copy machines. All of that cost has to be submitted in massive spreadsheets, all combined, looked at then from an analytical perspective to ultimately talk about what is an emerging rate that could be adopted. We got the analysis from that. It had a big price tag on it, y'all, a really big price tag on it. And still, our legislature authorized this in spring of 2024 this year. So we were provided $22 million in order to increase the reimbursement rate for non-Medicaid folks. And then we were provided the green light to move forward with also a Medicaid rate increase, which means authorizing the 32 cents of every one of the dollars that it's projected to cost in the future, so that we can then pull down those other 68 cents I was talking about earlier from the federal government. The good news is that rate study, that long year process that I talked about, we are at the end of that long process. Again, I was outlining what's already happened. We sent in May of 2024 this year to federal Medicaid the rates. Because it was just a rate study and it's very kind of analytical, nothing philosophical. Questions came back from CMS. We went back and forth a couple of times, and the rate increase was approved in October. That being said, let me just say, we got on it, and the new rate is being reimbursed to providers right now for all of our services. And the federal government approved it back to July 1st. So we are in the process of going back with providers and reconciling all of the claims they submitted, let's say back in July. They submitted a $10 claim, but now it's going to be reimbursed at $15. So they're going to get that extra $5 bump. And so we're going back now and reconciling all of that, which takes a lot of IT, a lot of hamsters on the wheel to tread that out, because it's a lot of transactional claims above and beyond what these IT systems normally manage. So we're staging that, and it's all rolling out right now. So what does that mean for you? We don't know. We don't mandate some of the things I'm about to say, but they're very important. And I'm going to do them quickly, looking at our time. But the majority part of the rate formula is based on wage assumptions. The last time we had a rate increase was in 2008. So what you see down this chart is we have 5 levels of practitioners. So certified peer specialists fall in the green and the black row. So individuals who are certified peer specialists who bill Medicaid are classified as either a U4 practitioner or a U5 practitioner. So the green row is the U4 practitioners, and the black row is the U5 practitioners. U4s have bachelor's degrees. U5 practitioners usually don't have a bachelor's degree. But you see the wage that the old rate was based on. And then you see beautifully the wage that the new rate is based on. So I'll take the green row. In the past, peer specialists with a bachelor's degree who would bill under the U4 modifier, the premise was that they made $36,000 a year. The new premise is that they make $53,000 a year. So maybe not the thrivable wage you might want, but most definitely more thrivable than 36K. Now, providers are not mandated to have these wages. But the more we're all able to talk about that this is the wage that the reimbursement rate was based on, then the more opportunity we have to create opportunities for dialogue about what a wage increase may look like for the provider who is getting now a higher reimbursement rate. So I'm hoping y'all are following me on that. That's like a lot of what I do, which people kind of laugh at, is I do financing. I do a lot of policy writing, but I have to do financing in Medicaid. And so I know these are sometimes higher concepts, and you're like, wait, I don't make 36,000, nor do I make 53,000. Who do I need to talk to about that? You can start with your supervisor. Your supervisor will probably have to go talk to some CFO, but start the conversations, y'all. If you're an LCSW in Georgia, which is that navy row right in the middle, and you're not making 76,000, those LCSWs are going to be having this conversation. Those LPCs are going to be having this conversation. And if you're an APRN, the light blue row, and you're not making 135K, then you need to be having those conversations, because that's what the market value is right now when we did a study. And so we know that this kind of stuff, this kind of information puts some high tension conversation potential out there, but we want you to be having high tension conversations if it means that you can negotiate up to a better wage. So I encourage you all to be having those conversations. And then, just so you know, as an example, the rate study across the board creates significant increases on the service reimbursement. So if you look at peer support, the second row, the range that peer support is increasing for reimbursement is a 23 to 49% rate increase. So that is some kind of awesome. That pays for the facility, the coffee machine, your insurance, your benefits, any continuing ed. So you're not saying your wage is going to go up, your salary is going to go up 49%. A ton of other costs have to be paid for by the rate. So including like the EHRs and just all of that stuff that's associated with delivering a service. So just be mindful of that as well. Okay, so the primary references I just have cited right here. And that is the end of my presentation.
Great information.
I
Thank
know
you,
that
Wendy.
didn't leave much time for questions,
So
but if anybody has anything they need to, and I couldn't track the chat at the same time, but I could stay, Alvin, for like 5 minutes if you can allow it, or if
Oh,
it's
absolutely.
term limited.
Yes,
I get
and will
that
we
too.
we have this the slides to send out to people after this? They've asked about
Absolutely.
that in the chat.
Yeah. Yeah, I'm happy to send those over.
Awesome. Who's got a question? You can raise your virtual hand down there under the participants.
And I think I see y'all were trying to answer the code of ethics conversation. That's good. I'm trying to skim the chat as well.
Mm-hmm.
I don't see the hand raising, Sue, but I have a question.
Who is that?
It's Mark
Hey,
Anthony.
Mark.
Hey, so being a U4 with a bachelor's degree, is that got to be a social or psychological bachelor's degree or any bachelor's degree?
There's a definition for that in the provider manual for it's usually what's considered a bachelor's degree in a human services field. So it's pretty broad. Your agency can work with you to self-determine. Like we usually don't have like a mathematics degree in that, but things like criminal justice, that's pretty broad. like school counseling has been kind of looped in there before. So we take a pretty broad definition of that, but that's up to you and your agency to decide if your bachelor's degree matches that, that human services scoping that's defined in the DBHTV provider manual.
Thank you.
I have a question.
Loretta's hand is up. Let's go with Loretta next.
Hey, thank you, Al and Miss Wendy. Thank you for this information. It's very, very good information. But my question is that these increases are through Medicaid's tenures as far as the services. The service has to come through Medicaid, correct? And then in Georgia, you're saying that we're not there, but we are once we start having a conversation. So does that mean that we could start conversating, because these ranges match the cost of living for Georgia to allow people to acquire housing? See, that's that piece that will help a lot of people, because the wage currently does not match the cost of living for a person to have adequate housing. Even in that peer support position, I think it will enhance more peers to come into the field to help one another in this process of our mental health and substance community, and they will be able to have adequate housing. I think that would be the plus to eliminate another area of homelessness.
Thank you, Loretta.
Yeah, for sure. I will just say that one point of clarity is that DBHDD for the uninsured that we serve, not if there's a contract. So like DBHDD has some contracts that are cost-based and we negotiate those, and those are like standalone. But where we do like a fee for service reimbursement, where we say if you provide one unit of peer support and it gets reimbursed by our partners at Carillon through that claim system, we are mirroring that rate. So state and Medicaid will be mirrored, unless it is just like a contract for something, like where we have CSUs and maybe a peer is working there. Like that rate won't adjust because it's all under a contract, or an RCO is a separate contract, Pure Wellness Respite Centers, separate contracts. But where we reimburse a claim, we are going to mirror those rates for consistency.
Tiffany, you have a question?
Yeah.
I do. Thank you so much, Wendy. A lot of information, really good information. I was wondering, when the reciprocity, does standardization have to happen before state reciprocity will? Because, you know, even in higher paying states, I'm still, you know, limited to be in Georgia because of my certification. So I'm not really able to relocate to do this, you know? So does it have to be addressed after standardization is my question.
No, well, what's happened so far, Tiffany, in like all these years, and many of you have experienced this because you've moved from elsewhere, the state has had like protocol where maybe if somebody's coming from another state, like you don't go through all the days of training, but you do a few days of the training, like Georgia specific stuff. Or maybe you just have come in at a time where folks are like, well, come in and take the test. If you take the test and you pass it, then clearly you had the information from the other state you were in. So there are some reciprocity protocols now that happen in states, but like not all of our 3 agencies in Georgia process it the same. And but we're looking at that this year. Like we've been taking some time to look at that, and there's some recommendations being made. And then it's been different points in time where we've thought about reciprocity from other states differently. But So reciprocity can happen now if, like, the Georgia Council and another state, like, they know that their curriculum are similar. There's been some adaptation and allowance for that, but nobody has a good standard for it. And that's what, when I'm talking about like reciprocity ahead, if agencies are self-certifying and they really like publish their, you know, that we meet these model standards and here's our self-assessment tool, and another state can look at it, they'll start to like say, absolutely. Like if somebody comes from Tennessee, we totally trust their certification and we're going to recognize it, and vice versa. So it's going to take some time to get to easier reciprocity, but reciprocity can and does happen now, but usually there's a little bit extra that has to happen for that certified peer specialist to get into that space in another state. So it's like a patchwork right now that's happening for reciprocity. No good standards published. The whole country is wanting to advance that, but it's just going to take a minute.
That's good information, Wendy. I'll tell you that I experienced that when I moved to Birmingham, and the UAB Medical Center was willing to use my Georgia certification until I could take the Alabama training. And as someone who gets those calls, I've also had people call from Texas and Oklahoma to ask if someone was certified in Georgia. So those two states are apparently doing something.
Right. And
Yeah.
again, like I said, it's like this patchwork. And we really want to be better than that. Like we want to advance the guild to a place where this is better. I tell you, those social workers have not done it well. There's just now these interstate compacts that are emerging for social workers and psychologists. So the neat thing is certified peer specialists aren't that behind, even though it's a much younger guild. I think we've grown so fast so quickly that then it's like, oh, we can do this, right? People are moving and coming and going, and we can look at each other's stuff and adapt and adopt. But like these old school guilds, like social work and psychology, we're real formal and we got to check every, dot every I and cross every T. But there are emerging what are called interstate compacts to do this for them. And slowly they're kind of coming into the light with that. And so the peer support, peer specialist guild is really kind of right on track with this. And I'm hopeful that we're not that far from having a good process for that.
That's awesome. Do you want another question, or are we about to wrap up? What do you think?
Let me take one more and then we'll say happy Thanksgiving to them.
So I have
Angie.
Angie. I have
Yeah,
Angie
okay.
Cannon. Oh,
Okay.
Karen. Did you
Hi,
want to say
Wendy.
something, Karen?
No, I did. I was just saying, Angie, because she does. I guess you don't know how to put your virtual hand up, but I know you. I've seen your hand, Angie.
Thank you. Thank you, Wendy, for the presentation. Very valuable content. My question is that benchmark for that 53K, that's on the billable sense through Medicaid. But what if you're with an organization that doesn't bill for Medicaid? Can conversations still be stemmed around, well, the benchmark is 53 in making negotiations for potential wage?
I wouldn't stop you from doing it.
Period. I wanted the clearance.
Yeah.
Okay.
Oh, well, I mean, it's not clearance from me, but here's
sure.
the thing. Here's the thing. The contracts that DBHCD has negotiated over time are based generally on proposals. And folks have kind of said, this is what we want to pay peer specialists. But you do that based on the market. So if your agency has entered into a contract that's like a 1 year or 3 year or 5 year contract, it may be stagnant for a while. But what you can talk about in the future is the market has changed, right? Because now Medicaid and DBHCD are paying higher. The market base then will increase. And so it's important, I think, that your planners in your agency or your CFOs or CEOs know this, even if they're not a Medicaid or fee-for-service, DBHCD fee-for-service provider, because when people start to look at average salaries in the future, they're going to be higher, and that's
Sure.
great for the field. But it's not necessarily this doesn't always convert to everybody's wage going up, but what it does is it creates an economic floor upon which all ships rise. And so for me, when you control Medicaid and the high volume for Medicaid, and you can push that out into the ether, then we get a lot of power and leverage for the future, for your personal futures. And really, when y'all are working and providing support and you're staying, then people have more access to you. And again, last time today, I'm going to do it, Alvin, but there's more of a chance that the person across the table from you supporting you in recovery is a certified peer specialist. So that is my dream. That's my dream for every Georgian who needs it. And that's what I will leave y'all with.
Yes, we are
Thanks,
the best
Wendy.
help. There's no doubt about that.
Yeah, and I know a couple of people are like, send me an email, y'all. Today's my last day, like doing that. I just packed my office next week. So y'all can talk amongst yourselves and talk to Dana McCrary at the office. And I wish you such joy and such beauty, and you just do amazing work. And so I will not be far from Larissa. I will not be far from the leadership at GMHCN and GPSN. I will be continuing to work, just not at DBHDD. And so stay tuned. I'm still out there in the ether pushing the growth and development of peer support.
Thank you.
That's awesome. Wendy, thank you for finding time for us here at the end of your day. This is great.
Thanks, Wendy.
Thank
It
you.
is. Like, I feel like I
Thank
should
you.
drop a mic. Like I said, it's just a blessing for my last official meeting to be with you brilliant people.
Thank you.
You will get your certificates for this CEU next week. We'll have the video loaded onto the CARES YouTube page in a few days. Thank you all so much for being here, taking time on a Friday afternoon. Thank you.
Great. Thank you.
Thank you.
Thanks for the
Thank
well
you.
wishes, everybody.
Thank you.
Yes,
Bye-bye.
Have a
bye.
good
Thank you,
time.
guys. Have a great weekend.
And Wendy, you'll send me a PDF. And she's
Ha-
gone.
Happy Thanksgiving, everybody.
All
Thank
right.
y'all very
too.
much.
Thank you all for coming. It was really great.
Thanks, Alvin.
Thank y'all. Y'all have a good one.
Bye.
Who you are.